Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hi, my name is Anastasia Hryhorczuk. I'm from CS Mott Children's Hospital at the University of Michigan in the Department of Radiology, and today we're going to be talking about ultrasound for pyloric stenosis. I have no disclosures today. Pyloric stenosis is a disease that we see in infants, typically within the 3rd to the 10th week of life. So these are some of our youngest infants. These patients will present with very forceful non-bilious emesis. If we have a patient with bilious emesis, we don't necessarily want to be thinking about pyloric stenosis. We want to think about other entities such as malrotation and midgut volvulus. With pyloric stenosis, ultrasound is our primary tool for diagnosis, and we have some general principles for measurement. If muscular thickness is less than 2 millimeters, that's okay. If the muscular thickness is 3 millimeters or more, that's too much. If the length of the pylorus is less than 14 millimeters, that's okay, but if it's over 18 millimeters, that's a bit long. But it's difficult to use absolute measurements. In the cine that we're seeing on the left of the slide, we can see the pyloric channel here, and just visually, the muscular layer of the pylorus appears quite thick. It's measuring over 5 millimeters in this patient. The length of the pylorus here is also greater than 2 centimeters, and we don't see any enteric contents passing through. An important thing to think about when measuring the pylorus is to think about where you are measuring the muscle thickness. You want to measure the entire muscle, which is the hypoechoic structure here, and you want to measure one side of the muscle. So from the external portion of the muscle to the internal portion here adjacent to the mucosa. The white arrows that I placed here show you where you would place your calipers to measure the pyloric wall appropriately. Here's another image of a patient with an abnormal pylorus. We see our pylorus here, adjacent to the gallbladder. We see the distal stomach here with fluid and debris. The pyloric channel is closed. The pyloric muscle, which is the darker hypoechoic structure that I'm putting the margins of my pointer on here, is very thick and it's not opening during our cine. This is all compatible with pyloric stenosis. The still images that we want to see during the study are a transverse still image like this and a longitudinal still image like this, demonstrating the pylorus. And in both of these, we can see that the pylorus is elongated and thickened. The pyloric thickness we would measure from the inner margin of the hypoechoic muscle to the outer margin of the hypoechoic muscle. And that would be too thick in this patient. And here with the arrow, we see the difference between the wall of the stomach and the adjacent pylorus. Right here, we can see the wall of the antrum of the stomach, which appears thin and normal, and we can see this change in caliber of the muscle as we enter the abnormal and thickened pylorus. Here is a cine clip of a normal pylorus that we're able to go through very quickly here. Right here, we see this normal pylorus. It's open. The muscle that we're seeing right here is very thin, and we see enteric contents passing through that normal pylorus. We can see that this is much more difficult to visualize than the large and abnormal pylorus. So, what are some pitfalls that we can have when we're trying to evaluate patients for pyloric stenosis? A first pitfall that we can have is the gastroesophageal junction. This can mimic the pylorus, and what you'll notice in cases where the gastroesophageal junction is being imaged instead of the pylorus, you may get images where you have the diaphragm and the heart in the images with the structure that is being described as the pylorus. And you don't see any images with the gallbladder and the pylorus in the same fields of view. So you want to make sure that some of the images in your study show the gallbladder and the pylorus. So let's look at this cine image here. We have a structure here that is labeled the pylorus. And the question is, do we think this is the pylorus? Well, we're pretty high. We can see the heart, we can see the IVC up here, and we're not seeing the gallbladder in the field of view. When we take still images of this structure, we can make this look like a somewhat elongated structure, although the muscle isn't that thick and we're just kind of measuring the entire channel here. This was labeled as the pylorus and suspected to be the pylorus. We also see that we have the diaphragm here, and we're not really in the expected location of the pylorus. None of these images are demonstrating a gallbladder near the pylorus. This patient's ultrasound was repeated the next morning, and here we can see we're showing the actual pylorus. All of those images were of the gastroesophageal junction. We see the pylorus here, right next to the falciform ligament, and this is a normal configuration. This is another patient where we were wondering if we were looking at the pylorus or not. These images are labeled as the pylorus, and we can see that we're seeing a structure of the luminal GI tract with gas and fluid passing through it. But when we look at this here, we can see that we're very close to the lungs and the diaphragm. We can see cardiac motion up here at the margin of our field of view. This is actually the gastroesophageal junction again, and not the pylorus. This is another patient where we were questioning whether we were seeing the pylorus or not. On the initial images that we see on the left of the slide, we can see that there's an area of the luminal GI tract here where some enteric contrast is passing. But as we see on the left side of this image here, we're at the level of the diaphragm. We see gas from the lungs, which is shadowing, and this is the gastroesophageal junction. When this patient returned for follow-up imaging, we went down towards the falciform ligament and the gallbladder, and we can see the actual pylorus here with enteric material that's passing through. This is the pylorus. The image on the left is the gastroesophageal junction. Another pitfall that we can see with these patients when we're examining them for pyloric stenosis is pylorospasm. This is an intermittent spasm of the pylorus that can mimic pyloric stenosis. You want to watch the patient for over 10 minutes to make sure that the spasm of the pylorus is continual and not intermittent. You can consider feeding the patients Pedialyte during the study to evaluate this further. Here is a patient where the image on the left was obtained as a still image, where there is suspicion that the patient had pyloric stenosis. We can see the muscle is here and it appears to be thickened. The length of the pyloric channel from here to here appears a bit too long. However, this patient was fed and the cine images on the right of the screen were obtained. With these images, we can see the pylorus here is opening up with gas and enteric contrast passing through the pyloric channel. This is a normal pylorus, which was demonstrating pylorospasm during the initial imaging. If you think someone may have pylorospasm, you want to feed them during the examination. Here's a patient that we thought might have pylorospasm. We gave them Pedialyte, and we can see now this gas and enteric material passing through the pyloric channel, which is able to open normally without evidence of pyloric stenosis. Another thing that you need to remember when you're looking at this ultrasound for pyloric stenosis is that pyloric stenosis develops over time. Pylorus may not meet all the criteria for abnormal on an initial study, and a repeat examination may be necessary to provide a clearer picture. So you really want to remember that pyloric stenosis develops over time. On the cine that we're seeing on the left of the slide, we see the patient on the day that they presented after their first episode of vomiting. We see the pyloric channel here. The muscle is a bit prominent. The channel looks a little bit longer, and we can see that there's enteric material within the stomach. This patient came back a few days later because they weren't felt to meet the criteria for pyloric stenosis on the initial image. And when they came back here, we can see the pyloric channel here, which is now more elongated with a bit more wall thickening. So the patient that I showed in the prior slide was actually hospitalized for other reasons during this development of pyloric stenosis. And even though they met criteria for pyloric stenosis, on the fourth day of hospitalization, they were not immediately taken to surgery. So we can see images on the left of the slide from day 6, where the pylorus continues to become elongated and thickened. By day 10, we can see the pylorus is even longer with a thicker muscular layer, and the channel continues to be closed. These findings are compatible with the way pyloric stenosis develops over time, turning a pylorus that might have once been normal into a very thickened and elongated pylorus by 10 or so days from maybe the initial symptoms. So, in conclusion, the important things that I want people to take away from this is that pyloric stenosis is something that we see in infants who are pretty young, really between 3 to 10 weeks, and this is primarily non-bilious emesis. If someone has bilious emesis, we should be thinking about other entities other than pyloric stenosis, such as malrotation and midgut volvulus. There are some pitfalls when practicing ultrasound for pyloric stenosis. First, the GE junction can often mimic the pylorus, so you want to make sure that you're identifying the gallbladder and the pylorus together. Additionally, you want to make sure that the patient doesn't have pylorospasm. You want to feed the patient and watch the pylorus over time. And you also want to remember pyloric stenosis may develop over time and follow-up studies may be required. Thank you.